Welcome to a new edition of What is Global Health podcast. Today we will be talking to Dr. Barun Mathema, an infectious disease epidemiologist and an assistant professor of epidemiology at Columbia University's Mailman School of Public Health. His work primarily focuses on the epidemiologic and biologic basis facilitating disease spread and avenues to better target disease control activities. Much of his work has dealt with transmission dynamics of tuberculosis, pathoadaptive evolution, and antibiotic resistance. His research spans not only domestic sites in the United States, but also international sites in nations including China, Moldova, India, and South Africa. The podcast will be divided into two parts. The first focused on tuberculosis and its epidemiological and sociological factors of global treatment, and the second focused on how to address global public health issues, specifically in the case of tuberculosis. This podcast is the second part of the series. You have experience working with tuberculosis within different cultures and nations such as China and South Africa. Why have you chosen to get involved with research abroad? What are some of the differences or difficulties you've encountered working with diverse communities?
You go where the burden is. But having said that, why those two particular places? I've also started working in Moldova, the Republic of Georgia, and a little bit in India as well. And at least South Africa was really sort of my launching pad. And I've also done some work in Nepal. But South Africa is partly because the rise of tuberculosis in South Africa really around maybe the late 90s, early 2000s was absolutely dramatic. The incidence of tuberculosis tripled in a matter of a very short time span, and it was coincident with the introduction and the rise of HIV. And it was so dramatic, and the need was so great, it almost caught everybody off guard. So South Africa was a really sort of a good place to not only ask a lot of academic questions about evolution, spread, epidemic trajectories, how the bugs are spreading, who's getting infected, how well are people doing on therapy, the rise of resistance, the spread of, we could ask all those questions because there were literally thousands of cases. South Africa also, I sometimes like to call it sort of this is being sort of not terribly PC, but sort of a third world country with first world infrastructure, right? So they have the problems that you typically find. South Africa is the wealthiest nation in the continent of Africa. And but the types of problems it has, as in this case, health problems, public health problems, mimic sort of, if you move up sort of towards the equator in Africa, a lot of HIV, a lot of TB, a lot of communities that have poor access to health care, so on and so forth. Yet there is a strong education system, wonderful infrastructure, so on and so forth, where, in a place like Nepal, you're literally backpacking from clinic to clinic. So you had this, doing the type of work that I do, at least some of it requires infrastructure. You need to transport, for example, if you collect a strain at a clinic, that strain needs to go into a laboratory, be subcultured, needs to be frozen, you need to be stored at -80. That means you need to have transport, you need to have the laboratory equipment to subculture the organism, freeze the organism in a special Revco sort of freezers. That also means you need to have electricity, right? So those are all real practical factors that really sometimes preclude people from doing research. Doesn't mean that it doesn't happen, it just becomes that much more difficult. So those are some of the practical factors, but South Africa, sort of needless to say, drew me in partly because it was so dramatic, and the need was very great. China, on the other hand, was a very different problem. I mean, China sort of has always had a TB problem, right? It didn't just happen. What was interesting, what I found very interesting in China is that, with the rapid rise of China, in the last 20 years or so, the economic sort of real boom, right? Double-digit, GDP, income, the economy is expanding very rapidly. Rural China sort of has been kind of left behind. And the tuberculosis dynamics in rural China was very different, not HIV driven. It was almost sort of an endemic situation. And so it was very interesting to, and again, one big factor I should add, and this is true with almost every researcher out there, is feasibility, right? Is where can you do work? And what that requires, especially when you're doing international work, is you need to have a strong partner on the other side. So some places, it's just very difficult because you don't have a partner, or they don't allow. For example, China, one big difficulty in China is they don't allow strains to be transported out of China. Yeah. It is absolutely a no-no. You cannot do that. Maybe if you're lucky, you can transport DNA. So that really hampers a lot of the studies that we can do, because from South Africa, a lot of those strains end up in the United States, and we regrow the strains, and we can really do a lot of testing on the strains. China, India also, you cannot send strains out. So that creates a bit of an obstacle, but it also creates an opportunity, right? It creates an opportunity insofar that you get to really do capacity building. So one thing that I'm very fond of, and I find very important in the work that I do, is to train. My colleagues are very, very competent and very sort of extraordinary scientists, but there's a whole battery of people who work in these infrastructures, young budding scientists in China, South Africa. So sometimes we bring them over to the US, we go there, and we do a lot of training. Not only of sort of general knowledge, but also of techniques. We try to write grants together, sort of bring them into the fold of sort of capacity building. But yes, every place has its difficulties, and there's cultural difficulties with communication. A big thing is actually something as mundane but very important as work ethic. Not to say that people work harder or less, but there's just a different style. And sort of, cultural practices and how you communicate, how openly you can communicate, how well you can sort of sit and sort of challenge the status quo. One has to be a little sensitive to cultural practices and sort of norms to really facilitate sort of productivity. But most importantly, of course, is building trust. And that really requires sort of respect and openness. And then once you build trust, I think people are people. So the obstacles are small. They're not minor and they're different. But at the end of the day, the common denominator is everybody's more or less the same in the way they respond to respect and openness and trustworthiness. So.
You speak about global collaboration in research and treatment, and some would argue that this kind of global collaboration is the best way to approach global and public health. Tuberculosis is not as prominent a public health issue in the United States as it is in other nations. Do we still have the responsibility to aid other countries?
The quick answer is yes, absolutely, wholeheartedly. But to answer that question a little bit more thoroughly is complicated, right? It's political, needless to say. So I am a part of the choir that believes in the fact that, the global health community is really a community. And so you help your community because, helping an individual perhaps 5,000 miles away sort of at the end of the day sort of helps humanity. Helping humanity is sort of helping yourself and your loved one, so on and so forth, right? But that's a lofty, that's a one world sort of vision that not necessarily everybody shares, because the counter argument is there are many problems, say in the United States, why should we be investing money to go abroad? And it's not a, it's a legitimate concern. It's a legitimate point. And I would address that from two perspectives. One is a humanistic perspective, right, which is sort of human rights and sort of a responsibility, if you will, to the global, to be a global citizen, right, to help those in need, and to really be a part of bettering sort of society. And I, wholeheartedly believe in that health is absolutely a right, and it should not be a right that's just based on privilege, right? And privilege could be people who live on the Upper East Side, sort of well-to-do people, or people who live in sort of more disenfranchised neighborhoods. Even in a wealthy country, we should have health. Health should not be something that is differential by, how much money you make or where you were born, right? The chances are, if you're born in Switzerland, it doesn't matter where you are in the spectrum of your income bracket, you have access to health, so you have that as a right. While in many other countries, it really depends. It's a bit like the lottery, what family you're born into, what access, so that should not be the case if we believe in that vision. Much like, having freedom of some sort should be a right, so on and so forth. So health is absolutely, it's a basic human need, and a basic human need should not be dictated by where you're from or how much money you make. Okay, so that's sort of a global village perspective. The other perspective, and one can look a little bit more inward, is that, well, tuberculosis, for example, we're talking about TB here. Tuberculosis, in this day and age of sort of global travel, people are, you can be on a plane in 36 hours and literally be at the corner of the world, wherever that may be. It could be Antarctica. People do come in and come out. There's infectious diseases move with people. Bugs don't move on their own. I mean, for the most part. I mean, they always hitchhike. It could be hitchhiking on a bird, on a fish, on a seal, but most often, in terms of what we do, with people, right? So TB sort of moves where people go. And so in this day and age where people move much, much more freely than they did even 20, 30 years ago, it is of national interest as well to deal with the global burden of diseases that may, in fact, impact a country like the United States. So that's why, for example, the United States has an international tuberculosis branch at the Centers for Disease Control. Or the European Union invests a lot of money in tuberculosis, certainly in their own populations, within Sweden, within Norway, Denmark, so on and so forth, France. But also they try to look at, well, where are people coming from? And so, but there's a fine balance there that one has to be careful of, right? Because it's easy to fall into the us and them, right? And this is certainly not where I'm going. And I think as public health individuals, we're especially doing international health with something like infectious diseases, and people sort of get scared, the Ebola outbreak and the epidemic in West Africa was a perfect example. There was a lot of fear of this sort of very scary disease emerging in parts of Africa, where there are people here calling for, well, let's cut out all, no airline, no air traffic coming in from. That doesn't really help. What helps is to go there and deal with the problem, right? So if we can decrease the global burden of tuberculosis, it will help decrease the burden of tuberculosis and may even help achieve elimination in countries like the United States, number one. Number two, tuberculosis has an extraordinary cost, economic cost. Extraordinary economic cost. So if the economies rise in countries that are disproportionately disenfranchised for various reasons, it sort of helps the global economy. So one can be a number cruncher and try to come up with reasons why, and they will be perfectly legitimate reasons, and one can also straddle the sort of human health, humanity perspective, and also be completely legitimate. And this is why we do it, other than our own interests and learning and knowledge and so on and so forth, right? This is why, from a public health perspective, it is important. This is why, even our last president, George W. Bush, he started PEPFAR. The president, I forget exactly what it stands for, but basically it's an action towards treating AIDS. About $6 billion was allocated. A good chunk of that is in sub-Saharan Africa to treat HIV. Why? Right? Good chunk of those patients are never making their way to the United States. Right? So it's this vision, and this was under the previous administration.
Tuberculosis has a vaccine and medications for treatment available. Yet not all populations around the world or even in our country have access to treatment that many take for granted. With recent discussion of the pharmaceutical industry, such as the Mailman EpiPen price controversy, what is your opinion on the public distribution of medication? Especially considering the extensive treatment of tuberculosis, which you mentioned can span up to 18 to 24 months, how can populations you described as disenfranchised access medication for treatment?
So let me first address your point on the vaccine. There is a tuberculosis vaccine, and it is probably the most widespread use vaccine in the world. It's called BCG. And it's one of the oldest vaccines. The problem is, it doesn't really work, right? And there's a lot of controversy and a lot of sort of conflicting results, but the general consensus is that BCG protects against childhood tuberculosis, severe forms of childhood tuberculosis, but does not protect against adult tuberculosis. So if you are born in a country, certainly outside of the United States, or if you were born in the United States after, I forget when they stopped using BCG here, maybe at some point in the 60s, you in the United States will not have gotten BCG, but I have BCG. Perhaps people that you may know, or your friends, or who are from other parts of the world, would have had BCG. So again, the thinking there is that, and BCG is essentially universally available. So this was, again, a global health strategy really dictated by the WHO, right? Where BCG is now a part of the immunization program. That, so when you're a baby, if you're a little baby in South India in a small clinic, you get vaccinated for various things like polio, right? BCG would be one of those vaccines you get. So that's great, except for the fact that it doesn't really protect you against active tuberculosis. Okay, but now we're coming to medication, and this becomes a much, much more critical issue. The good news is also that the global community, WHO, and the Global Fund more recently, have really made tuberculosis therapy more or less free everywhere in the world. So countries, you can go to Ghana in West Africa, and the Ministry of Health will have allocated certain funds, sometimes through grant money, donor aid, also through their own budgets, to support the tuberculosis program. And within that support of the tuberculosis program is procurement of medication, right, at government clinics. But that's mostly to first-line medication, meaning that if you have, I would say, the run-of-the-mill tuberculosis, i.e. not drug-resistant tuberculosis. So that's 6 months. One problem that immediately comes up is you need to have access to that government health clinic, number one. So you can argue that you do have access. This is a government clinic. Number two is you need to have faith that you believe that the government clinic is good. which turns out to be a lot more difficult. I mean, you see it even in discussions here about other health issues, that sometimes patients will not necessarily go to government clinics because they don't have a lot of faith in them, because of bureaucratic issues, political instability, so on and so forth. So sometimes you come to the government clinic, there's a political instability, there's no drugs available because there's a shortage. The supply chain has been hampered. What do you do? It's a big problem, right? So there's that issue. But now when we're talking about dealing with things like multi-drug resistant tuberculosis or extensively drug resistant tuberculosis, so it's like you're going up in the categories of resistance. The drugs, there are many, and they're expensive. And not only are they expensive to procure and to give, they also raise a lot of other health issues, side effects. So you have to manage those. That is turning out to be a much bigger problem, because a country like South Africa that has a large multi-drug resistant population has invested a considerable amount of their own resources, as well as gotten funds from the Global Fund and other entities to procure and to buy these drugs. And while they may be getting sort of better deal than we get in the United States, they're still very expensive. They take a good chunk of your budget. In certain places, in other places, first-line drug therapy, which is sort of your run-of-the-mill TB, is free. But multi-drug resistant therapy, you have to pay for out of pocket. And so it ends up becoming unaffordable. So there's, again, now we're back to the disparities issue and access. So this is a massive issue. Again, coming back to tuberculosis therapy is something that everyone, doesn't matter what kind of TB you have, should have access to, partly because averting one case saves you a lot of money. Again, if you're a number cruncher, which obviously a lot of policymakers are, you sort of need to boil it down to dollar value, unfortunately. One infectious person can infect a number of individuals, and some portion of that infected pool then will go on to become diseased again. And you can imagine when somebody is diseased or sick, before they actually seek health care, they're not feeling well, they may skip work, so on and so forth. So it takes a big toll. So it's an economic toll, let alone sort of your personal well-being and your loved ones, so on and so forth, social toll. So there is a lot of interest in governments to provide tuberculosis therapy and to put people on treatment. But availability and stable availability of drugs is not so simple always, as well as certainly for tackling issues of multi-drug resistance and extensively drug resistance, where you now need literally a cocktail, 5-6 drugs, and they are, again, not the typical drugs that you will find in a pharmacy. So this becomes a very big issue. It's a huge, huge, huge issue, and even now there's a good swath of people who still don't have access for a variety of reasons, again, because somehow there's instability. So for example, when the Ebola epidemic was going on, I don't think anybody was getting access to TB meds. I don't think any TB meds were going in. Nobody was going in, unless you were wearing a spacesuit, right? Right? So you can imagine the number of people who may have died from tuberculosis, from malaria, from a variety of other things other than Ebola, arguably more. Diarrheal diseases, a little child having diarrhea. Diarrhea is one of the number one killers in the world because of a variety of reasons, often poor sanitation and contaminated water. Think about the number of children who, and you die from diarrhea based from dehydration. Nobody was going to the clinics to see their doctors. They were afraid to go to the clinics. So you can imagine what the toll must have been like. So, that's a dramatic example, but there's war, there's migration. what's happening in Syria, the sort of mass exodus from Syria. There's a very interesting paper that recently came out looking at the strain analysis. So the impact of armed conflict, in this case, it was the conflict in Afghanistan in the 80s, where the Soviets came in, and the displacement of individuals, the introduction of massive groups of people in one, so where people move is where TB goes. And, in the case like, in a disease like TB. So yes, it's a very good question, and it's unfortunately it's a really difficult question to completely sort of answer succinctly, but access is a massive issue, and continues to be so. So some will even say, even if we need new drugs for TB, some of the people say, well, what's the point? We still can't even give the ones that we have currently.
How have you confronted this balance between researching for new treatments and providing these treatments?
So public health, one of the things that public health often straddles with is, right, and something I sort of tackle and sort of struggle with is particularly in a disease like tuberculosis, a good chunk of the tuberculosis problems from a public health standpoint are operational, right? How do you make sure somebody stays on their medication? Do they have the medication? Do they have the right diagnosis? How do you give them the right diagnosis? Is the clinic equipped with XYZ, equipment? And we're not talking fancy equipment. Are the healthcare professionals paid enough so they are willing to stay the number of hours so the patient doesn't have to wait 7 hours to be seen? So on and so forth. These are really big issues, and one can argue you don't need to necessarily. This is not rocket science per se, right? But they are really difficult issues because you're dealing with people. You're dealing with people, and you're dealing with politics. You're dealing with structural. There are many obstacles. You're not dealing with just the organism. A former colleague of mine, and this is a little facetious, but used to say that he liked working with the organisms, the pathogens themselves, because people lie, bugs don't. That's what he used to say. It's very simple, straightforward. People are complicated. Societies are complicated.
As a closing question, what do you, as a public health researcher and professor, see in the coming years, especially in light of our recent national politics, for public and global health policies? And how can citizens play a role in developing these policies?
To be completely honest, I am not sure. My guess is that for the most part, there will be some semblance of status quo. We will continue with certain aspects of even our global health initiative, certainly from the United States. However, there are certain things that are at risk, or I should say at risk or unknown, right? So just here in the United States, the idea of healthcare and access to healthcare, who has access, how affordable is it, so on and so forth. What kind of emphasis are people going to pay? What is the premium policymakers would put in having sort of universal access, dare I say? I think, it's a really exciting time to be involved in public health and sort of the whole notion of global citizenship, right? Health, again, there's many sort of really amazing causes out there, but sort of at the end of the day, and this is what I was alluding to earlier, health is a basic human need, right? And we've actually made a lot of progress. Progress in not only in delivering care and knowledge and treatment through the far corners of the world, but also through activism and involvement and participation. And it's possible. Now as an undergraduate student, you could be in Nepal, either helping to build a home, volunteering at a clinic, or just sort of learning about cultures. But when you sort of string all of these aspects together, one can really actually make a big impact on how sort of health is shaped, because unlike before, access to going to other parts of the world, or even access to funding, was very difficult. Now the global health community has sort of, or the world has sort of opened up, if you will. And the time is really now. And, of course, the time is always now, right? And the urgency is always, it should have happened yesterday, right? So, I would say sort of call to arms really is that, it is, I think, actually imperative that the sort of younger generation get involved not only in health, but sort of taking charge of sort of your society. And when you say your society, it could be your neighborhood, and it could be something much larger than that. And it could be a cause like tuberculosis, it could be a cause like Ebola, it could be a cause like housing, which all, again, everything comes back to health and well-being. And the contributions, again, that even a sort of one individual can make. This sounds very cliched, right? But it's very true, and there's many examples, even certainly from this school, where we've had master's level students really starting something amazing, and really sort of inspiring, and building relationships that sometimes last their entire careers, and really pave the way for other students, not only to learn for themselves, but really to make an impact. So yes, now.